I open the second section of our seminar, Legislation and Facilitation of Data for Research in Norway and Europe. My name is Marit Halvorsen. I'm a professor at the Law Faculty down the street here. In this session, we will explore how to facilitate the use of the huge amount of data collected. Ethical considerations stay up front, of course, but the legislator has not trusted the scientific community to handle the use of biobanks on their own. The use and exchange of biobank material and information is heavily regulated, both through international law, for example, from the Council of Europe and from the European Union, and by national law. The legislator aims to do several things at once, both to facilitate good and responsible research and to protect the individual and their privacy, and this is no easy task. And I suspect that the researchers sometimes have found that the law is more of an obstacle than a help, unfortunately. As a lawyer, I say this. However, national and international collaboration in the biobank research field is important. The lawmakers and the scientific community need to engage in continuous conversations about this to facilitate that great endeavor. And that is exactly what we are doing in this session. And I first welcome Camilla Stoltenberg. Her title is National Organization. She's Director General, Norwegian Institute of Public Health, and has a past in epidemiology. So welcome, Camilla Stoltenberg.
So thank you for inviting me to this meeting. I'm not going to speak about what I've been asked to speak about. And the reason is that I think that I've been speaking so much about that for so many years, so you're probably bored hearing me telling you exactly how many samples we have, how they're regulated, and how it's organized. But I will answer questions about those issues if you want after my presentation. What I'll do here is more reflections on how we should communicate and think about what we are aiming at in this field. And it's a bit risky even for me to speak about these topics, but I'll try. The reason why I'm doing this is that I think that the biobank registry cohort community has not been sufficiently good at explaining to the general public, to politicians, and to ourselves, why do we need these resources to do research? Why are we doing it? And why is it so important to get better access and to get better infrastructures? And I also think that we should take a step back and think of it not only in the framework of health research, medical research, but also in the framework of creating a knowledge-based or evidence-based society. So that's what I'm going to speak about. Now, to move up to the highest level, these are the 17 Sustainable Development Goals that were approved by the UN in September 2015. And why are they relevant for biobanks, registries, and cohorts? Well, if you look at the details, the documents explaining how we are going to reach all these aims, they all point to the need for documentation, evidence, research, in order to reach the aims, in order to survey and monitor whether we are on the right track, whether we are spending our resources in the right way. And actually, by citing some of the documents here, we will get some of the strongest arguments for why we need the kind of data that we are arguing that we should have. Also, if you take a closer look here, you will see that aim 3 is the health aim, good health and well-being. And if we reorganize these 17 general aims that pertain to all kinds of countries, low and middle and high income countries, and that we are all obliged to try to reach. for ourselves and for the rest of the world, then we can look at it in this way. The aim 3, good health and well-being, says that we shall ensure healthy lives and promote well-being for all at all ages. And this picture is just illustrating how that relates to all the other aims, whether it's on education, hunger, poverty, or industry. So let's move from the global level to the national level. At the national level, we of course have general research strategies. I've chosen here just to illustrate my point by using the research and innovation strategy for the health field, called Helse Omsorg 21, Health and Care for the 21st Century. And you see there to the right the document itself, the strategy that was presented for the government in 2014. And then the vision, which I've forgotten to translate. So that says that the vision is that we shall have knowledge, innovation, and development of industries for better public health. So that's the vision. And the triangle here illustrates that good public health is the overarching aim, and that encompasses health and care services in this case. And then we have a separate research aim, which is an aim and on its own, but also supporting the other aims, and a third aim on industry and economic development. And for all of these aims, we need knowledge, research and development, innovation and education. And many of us, even in this room, are involved in trying to implement this strategy in Norway. And it is very similar to strategies that we find in other Nordic countries and in many other countries across the world. So we need knowledge both for health and for society, and in my view, we need more knowledge. There are many knowledge gaps. We need better knowledge. We need much clearer ideas about what quality knowledge should have, what quality we should have on scientific projects and programs. And we need it faster, because so much of what we are doing comes too late. It's still publishable because the knowledge gaps are so big, but we have so many examples of how it takes so long to generate the knowledge that once it's there, the world has moved. So we need it much, much faster. We also, of course, need to secure confidentiality and individual rights while we are developing more, better and faster knowledge. So this is an old picture that I think I got from Mats Melby originally, this is actually the vision for what we are doing. In order to create this knowledge, we need to turn an entire country, or perhaps many more countries, into cohorts, so that all the data, not all of them, but all the data that are generated routinely in a society can be organized and made accessible for research and analytic purposes. So for public health, that means to increase life expectancy, improve health and well-being, and reduce inequity. For the health system, it means that it shall be patient and user-oriented, effective and efficient, and have high-quality care. And for research, it means to generate knowledge, new knowledge and discovery, innovation, and economic and social development. And what kind of data do we need? Now we are turning to the topic of this conference. And I will use this picture that I've used many times before, which is illustrating what is the case for the Nordic countries at least, where everyone is recorded in one or many registries, whether they are health registries or other kinds of registries, such as socio-demographic registries. Many people participate, at least in Norway's case, probably 1/5 of the population, but at least more than 500,000, participate actively in large population-based cohorts, such as the mother and child cohort study, the Tromsø and the Hunt study. And almost all of us contribute to biobanks either through such cohorts or through routine collection of biological samples in the health and care services. And we also contribute clinical data either in cohorts or other research projects or routinely. And we should try to build on this infrastructure that is already there and to make it more perfect and more available and more of a general infrastructure for research. And I also think we need to see this in the framework of research in other fields than only health. Now, what kind of knowledge do we need? We need knowledge on distribution, incidence, prevalence, etc., over time between different groups in society. We need knowledge about causes. We need a lot of knowledge on effects of everything from policies to specific medication, on costs, and on personal experiences. How did it feel? What happened? A very good illustration of the massive kinds of data that we need is given by the Global Burden of Disease project, where at least 188 countries in the world are participating, and the very strong research center in Seattle is collaborating with many governments in creating burden of disease analysis. And only a few weeks back, they were able to publish 2015 data only shortly after 2015. So they have become much more comprehensive. They have very high standards for quality of research and very high standards now on how fast and relevant the research shall be. But this is basically very simple descriptive epidemiology. They are not doing real discoveries, but they are moving into at least not only describing distributions of diseases and risk factors, but also in analyzing effects of policies, looking at inequity, etc. Now, what is the overall aim? I think the overall aim is to build a knowledge system, at least for health and hopefully also for society in general. But how shall we do that? In the Norwegian government declaration from 2013, knowledge has a very prominent place. And I'm not going to read all of this to you, but it's just a reminder of how the current government spoke about knowledge when they went into government. I'll read just the last citation. The basis for our future value production and welfare lies in the realization of a knowledge-based society. And these are the most prominent examples of how they speak about knowledge, but there are several others. They also promoted the idea that one should test out policies by doing some kind of randomized controlled trials, or at least trials when they wanted to implement policies. Not much of that has been implemented yet, but I think that in Norway, where we have an election next year, what we can hope for from our group of people working on these infrastructures is that there will be a renewed interest in looking at what concretely can we do to work or to promote a knowledge-based society, and that the parties in government will compete with the opposition in trying to be best at doing this in a good way. So I think there's a lot of opportunity, at least in this country, for the next year to come, if we are able to communicate the importance of what this is about. Another kind of inspiration is President Obama, who launched the Commission on Evidence-Based Policymaking in April this year. And that was actually a bipartisan initiative, so it's supported broadly politically in the US. And it looks very much like some of the things that we are trying to do. The mandate of the Commission is to explore how to open up federal data sources for more useful analysis and research, examine how to connect data sets, linkage between registries, develop a vision for a comprehensive data clearinghouse, recommend robust ways to evaluate program design, and figure out how to do all this while protecting privacy and security. It's very simple. It's very hard for them. I was invited to speak at the National Academy of Education Research in Washington, D.C. in August this year, and they are adamant that they want to do this, but they don't have access to routine data today. And it's much, much harder for them to reach the aims of this commission than it is for us, although they are much better at launching such initiatives than we are. Now, the other initiative that I know you've already been discussing, or at least been presented for earlier today, is the Precision Medicine Initiative. And I, in many ways, see this as, in a way, a part of the other overarching initiative. I don't think anybody else has made that link, but I think that one way of conceptualizing this is to think that the Precision Medicine Initiative is contributing to, or will, if it succeeds, contribute to a knowledge-based society and has much broader implications than only discovery, not that that is only, that is very important, discovery of new drugs or looking at how genetic factors influence disease. So what about the Nordic countries and Norway? We can do all of this faster, better, larger, and less expensive than the US and most other countries in the world. And we already, as you all know, have registries, cohorts, and biobanks in place. We have, which I think is incredibly important, although there are some limitations to our regulations, I think one of the main things that we have achieved over the last few decades in health research is much better regulatory control and governance. So although it has some side effects and needs to be adjusted, that is a major achievement. And it should not be, it should be respected as such and just developed further, building on what's been achieved. So I'll skip this one, but no, I won't skip it. How is confidentiality and autonomy secured? I think that, of course, one of the main ways we are securing it is by having democracy, peace, and trust. Sort of the overall most important basis for doing this kind of research at all, and that individual rights are legally secured. What is so good is that all these data sets potentially include all inhabitants in our society, with some exceptions. But we have sparse information on each person in registries without informed consent, while we can have more in databases with informed consent. And informed consent is increasingly becoming more dynamic in many different ways. We have ethical approval systems and, to an increasing extent, but still much too limited in my view, access to our own data. And we can demonstrate that all of this is useful. But that is the point that, which is my main point here. We need to do that much better than what we are doing it at the moment. So the challenges that we are facing is that although there is a lot of trust, it is limited and sometimes threatened for good reasons and some bad. Regulations are complicated and organization is fragmented. Access is time-consuming, data are not being used, results are not fed back. Data capture is often still separate from clinical recording and data are not shared. The opportunities we have is that we can have reality-based research. So when randomized controlled trials are not possible, or even when they are possible, we can embed them in a registry system where we proceed and follow up the randomized controlled trials. So these two approaches are in many ways complementary in my view. We have new methodological approaches that will be addressed tomorrow morning based on registries that can combine advantages from the randomized controlled trials with those from registry-based observational epidemiology. We can have long-term follow-up, big numbers and powerful results on selected populations or the opportunity to assess selection. We can look at many exposures and outcomes and evaluate them simultaneously. It's safe and gentle for participants to be investigated through registries, biobanks, and cohorts rather than through interventions. And we have good protection of privacy. We can secure individual rights, and it's very cost effective to have such, or potentially very cost effective, to have such infrastructures. And they provide a basis for many kinds of research, which we see is developing currently rapidly. So my questions to you are, do we understand and communicate the value of research and knowledge in our society? If we did so, I think we would have a much simpler infrastructure, because if it was realized how important this is to our society, it wouldn't be so difficult to get access to the data. And do we distinguish between the risks involved in data for health services or for running our society, to take that broader view, and on the other hand, using the data in research? I think that so much of the blame of the risk has been placed on research, and therefore research is being hindered or blocked. But most of the risk is actually there already just by having the data and using them for their primary purposes, which is to run the healthcare system or run our societies. So how can we change the system? Because this system needs to be changed. I have presented this just as an idea. I don't know if it's a good idea, but I want it to be discussed. There is in Norway, and I suppose in most countries, a national transportation plan. And perhaps we could need a national knowledge or research plan. Would that be helpful? Would that make us create a much better and more efficient infrastructure so that we could compete about good ideas and good analysis rather than owning data? Thank you. There should be some time for questions.
Yes, thank you very much, Camilla Stoltenberg. And of course, you've been very time efficient, so there is a lot of time for questions, and I hope the audience will engage in questions to you, and I just leave the podium and the microphone to you.
That was on purpose. I wanted there to be time, both to respond to questions or comments about what I've said, but also to all of the issues that I haven't addressed that I should have spoken about. How we are regulating and how we have organized our registries, cohorts, and biobanks in Norway, and the regulatory issues. Christian?
If I remember correctly, you have several times said that the Health Research Act needs to be revised and renewed. Could you elaborate a little bit on that one?
I will. I was involved in the committee that proposed the Health Research Act, and we did something that I think was a big mistake, because first we discussed how we could, I hope I'm able to say all this in English, how we could create system that would not allow risky research on individuals to not be evaluated ethically in the ethical committees, because it's been done under the name of quality assurance or just implementation of some new clinical practice, not under the name of research. So we said that we should include what has traditionally been called quality assurance, for example, if it means that it's risky for the individual and represents the same kind of risk that research does. So that happened early in the process. And then later in the process, we returned to looking at the aim of the whole act. And we said that this should be an act supporting that we should do research in a safe way, forsvarlig, but also that we should promote research. And then we said that in order to define research, it shouldn't only use scientific methods, but it should also aim at creating new knowledge. But then we sort of missed the point with the quality assurance part, because the risk may be equally high for patients or participants, regardless of whether you're trying to get new knowledge or you're just doing it. And that means that when the ethical committees that are already overloaded with work tried to sort of limit what they were going to work on, they said that we have to draw a line between research and what's not research. And so they left out all the kinds of studies that are even published, but that are not aiming at actually making new discoveries or getting new knowledge. So that means that it created a gap where many projects have not been able to get approvals. And they've been sort of struggling in some limbo. That goes, for example, for the global burden or the burden of disease project in Norway. It's been tremendously hard to get ethical approval because they say, we will establish this system and then we will do more or less the same thing all the time. But they publish all their papers in Lancet. So basically it's research, but it's not called research by the ethical committees. So that's one issue. Another issue is, and I was opposed to that myself in the committee, that research based on secondary use of data, both from samples, analysis of samples, and from registries and cohorts, is regulated equally strict on a specific level as research where you, for example, take samples from patients who have just developed diabetes and you take biopsies from their pancreas. So it's as if that was the same kind of risk. And I think that we should look at whether it would be better to do something more similar to what they have in Denmark, where you don't need approval for all the specific projects if you use data secondarily. I mean, you reuse data or you use registry data. You could give approval to institutions, for example, or you could do it in bylaws, so that we could cut all those studies so they wouldn't have to apply to the ethical committees, but could have some obligation to have a list of studies that you're running and how you secure your data. And another issue that I don't think we addressed sufficiently in the Health Research Act is data sharing. And again, I was the only one who tried to promote that, but I didn't get much support at the time, and so I gave up on that before it came to the law. But I think that basically all data generated routinely, they should be a common good. It's not as if gastroenterologist owns his patient's data or that department or that hospital. Now at least it's up to a hospital level, more or less, but at that time it was even worse. So we haven't really addressed data sharing and sharing of samples and how we shall deal with that system. So that's only 3 issues. There are several other issues. But I think now that the law was implemented in 2009 and needs to be evaluated and revised, because it hasn't really reached all the aims it set out to reach. It has had some very good effects also, but these are some of the complications. Any other questions? Rolf?
Thank you for a very fascinating talk, and I think you have been the changer over the years for this field more than anyone else. And I'm fascinated by your suggestion of a national transport plan. Being from the Western country and following the discussions on E39 along the coast, it's very nice to see where the discussions are going. It should go from A to B. But then where it should go in between A and B is a totally different discussion. But the good thing is that you can have the big picture and a continuous discussion. Could you elaborate a little bit on who you would think, which, if it's a ministry level, who should have the responsibility, how to rotate it? Because that would be the good thing. It's a continuous rotation, not a full speed ahead, full stop process, but a continuous process.
If I understood your question correctly, I think that the ministry that should probably, I don't have very strong opinions on this, but it would probably be Kunnskapsdepartementet, the knowledge ministry, who should drive this forward. And regarding an infrastructure for knowledge, I think that that is the best thing we can do to make innovation and development of industries easier than today. And I think it needs to be a very generalized infrastructure, and that's why I like the analogy to roads and traffic, because you don't build one road for ambulances for the health system and then another road for commercial driving and a third road for tourists. You don't do that. And also we've more or less stopped making our own private roads in this country that are not linked with each other. We have national plans for how we develop roads and traffic systems, and we can't have a lot of organizations and institutions that set up their own, vad heter bompenger? their own, toll stations along the roads, sort of based on their, or like Statistics Norway has done, they just decide their own price on their toll station, and then somebody else has a completely different system and a completely different price. So all of this can be solved. It's been solved before in other sectors, and it would be so incredibly helpful, and it would make it safer, and it would increase the speed. Then we have to take care of the quality also, but at least it wouldn't hinder development of good quality. Time for one more question, perhaps? Or you're the boss.
Yeah, I really enjoyed your talk. It was fascinating, and I would, I mean, if I would hear something like this in this of a Swedish general director, I would be very pleased. I would be very pleased. The one thing that I thought about when you really, that I really enjoyed hearing was that you took sort of the randomized control trial as, when we cannot do randomized control trial, we can do observational study in order to do evidence-based policies. And that I really, and putting this sort of into that this way is to reduce the risks. Randomized control trial is much more risky than to use observational studies. So having this kind of focus is really nice that you brought it up. So one thing that I also thought about when you said that the risk is of having the data, really. And I agree on that. But there are different risks. So if you have administrative data, the risks are already there. But if you collect prospective data, it's another situation. So if you could sort of develop or think about how do you think about that? When you collect data, this means that you increase the risk of the population under study to some extent.
Well, I think that if we worked on the data that are collected routinely and how we handle those, that would be the bulk of the data. There would be much less need for separate data collections, and they would be much more specific and limited than what they tend to be today, because we don't have access, or we don't have sufficient access, and we don't have sufficient quality and sort of curation of the routine data. So I agree that if you create new databases that wouldn't have been in place only through routine data collection, that creates new risks, but there would be much less of it. And if people also had much more insight and direct access to their own data, that would be a different situation. It would be much easier to communicate with people.
Oh, thank you.
Your time is up, but thank you very much for an interesting presentation. This was,